But yes, I have given 3 classifications of RPGN. Rapidly progressive glomerulonephritis. Definitely the 3 categories I have said. The post-immune means the rapidly progressive glomerulonephritis, RPGN, the terms used to describe the rapid loss of renal function as well as the formation of epithelial crescents, as I said in the majority of the glomeruli. Hemophilia, the word is to say the hemo means blood, philia means love. Loving for the blood means he needs the blood. So he has been going through the blood transfusion. Hello, my dear doctor. Welcome to the very important lectures that I'm going to do now. That is RPGN, my dear. RPGN is a rapidly progressive glomerulonephritis. Under the headings of the RPGN, there is a variety of the disorders are very, very highly important for your exams, my dear. For MRCP Part 1, Part 2, and also sometimes the clinical exams, and also in some specialty certificate examinations as well. So my dear doctor, listen very carefully. Knowing the facts and some of the important differential points of the different varieties of diseases under the headings of the RPGN is a very hot topic for the exam, and knowing these facts will be really, really helpful to cleanse the diagnosis, to grip the diagnosis confidently, and to differentiate other differential diagnoses and making the answers correctly with confidence, my dear. I'd like to describe a variety of disorders in these lectures, my dear. Just follow me what I'm going to do. I'd like to give a good headings. There is a RPGN, there is a rapidly progressive glomerulonephritis. Under the headings of the RPGN, there are the diseases, variety of disease I'll discuss, but among them, the GPS, yes, my dear, Goodpasture syndrome, and after that, the GPA means the Granulomatosis with PolyAngiitis, the previous name, the Wegener's granulomatosis, and next the MPA, Microscopic PolyAngiitis, and next is the EGPA, yes, my dear, Eosinophilic granulomatosis with PolyAngiitis. The older name is a Strauss syndrome, my dear, and also other differential diagnoses of this variety of the diseases are very hot topic for the exam, my dear. So yes, my dear doctor, listen very carefully. I'd like to start with the RPGN and very good ways of systemic ways of learning of the different diseases that I said, and also after having some of the differential diagnosis of each and every diseases altogether, and after that having some of the splitted fine-tuned knowledge how to clinch the diagnosis in a given scenarios in your exams, and immediately after that I'll go through the different questions and scenarios so that you can apply your knowledges into the questions and scenarios and getting the diagnosis and getting the right answers correctly with confidence, my dear. So let's start. Yes, my dear, just follow me very, very carefully onto the board. So let me start by writing, as I said, the word that I say start with the RPGN, my dear. I like to give the SS boxes, the lectures, the main component is an RPGN, my dear. So my dear, this RPGN means the rapidly progressive glomerulonephritis. What I said? Rapidly progressive glomerulonephritis. My dear, it's a glomerulonephritis, means a glomerular disease. You already gone through the lectures, the glomerular disease. The glomerular disease can be presented in a variety of ways. Starting with the hematuria, asymptomatic hematuria or asymptomatic hypertension, first one, and then hematuria, proteinuria, microscopic hematuria to gross hematuria, microalbuminuria to proteinuria, massive proteinuria, and then nephritic syndrome and nephrotic syndrome. I call the nose and knees, and then AKI and CKD, and combinations of all this together can be presented, my dear. I know already you have gone through the lectures how the glomerular disease can present, my dear. But the typical ways of the presentation, among them presentations, the different glomerular diseases that we have, we already learned the different diseases, starting with the IgA nephropathy, and also the PHGN means the post-eruptive glomerulonephritis. And immediately after that, you learned already MCD and MGN. It calls there is a minimal change disease and membranous glomerulonephritis. And next to these 4 diseases, there is a MCGN and FSGS, my dear. MCGN means mesangiocapillary glomerulonephritis, and FSGS means the focal segmental glomerulosclerosis. And the last disease is an RPGN is a rapidly progressive glomerulonephritis. So these are the 7 glomerular diseases can present in a variety of ways. The 7 presentations or 8 presentation of glomerular presentation, starting with the hypertension, as I said, the hematuria, proteinuria, and the nose and knees means the nephrotic syndrome, and AKI and SsAcademy, and combinations of all them together in a variety of presentations of these 7 glomerular diseases. Among these 7, I am discussing now the RPGN. There is a rapidly progressive glomerulonephritis, my dear. The word itself says that the rapidly glomerular damage will be happen by the process of, definitely by the process of glomerular damage means the autoantibody destructions, my dear. This rapidly progressive glomerulonephritis, the word itself says that usually they are presenting in a different varieties of ways. But the most common presentations is nephritic syndrome leading to AKI, acute kidney injury. Yes, the RPGN, usually the rapid word, they will damage the glomerulus. Classically, the nephritic syndrome, it can be varieties of the ways, as I say, the different presentations, but they are typically the nephritic syndrome leading to acute kidney injury. So yes, my dear, that is one of the box that you need to know, my dear. Because of the rapid destruction of glomerulus and the immune process, the immune complexes are destructing the glomerulus, that leads to the formation of the crescents. So that's why this glomerulonephritis, the another name is crescentic glomerulonephritis. I am writing CRGN, my dear. The another name you can use, the crescentic glomerulonephritis, you will see the photo of the glomerulus. Yes, my dear, they will form some crescent shape of the immune complexes that destructing the glomerulus that leads to the glomerulonephritis. So I would love to say this is crescentic glomerulonephritis, my dear. So what I am saying, my dear, yes, this is rapidly progressive glomerulonephritis that leads to the AKI and in the form of the knees nephrotic syndrome and crescentic glomerulonephritis. The word is says once again, as you think about it, the nephritic syndrome, what does it really mean? Nephritic syndrome. Nephritic syndrome, at least more equal to diagnostic criteria that should be present. The most important criteria is in hematuria and of course hypertension and hematuria. I am saying the hypertension and next the hematuria. Yes. These are the 2 important diagnostic criteria. Along with they may have some of the proteinuria, yes, and oliguria, yes, my dear, and maybe other features, my dear, and sometimes a part of the AKI. But these 2 important features that should be present for the nephritic syndrome. And acute kidney injury means the acute rise of, yes, my dear, the creatinine. It is said that the acute means at least the less than 3 months if the creatinine is raised, and very simple, the urine output will be reduced. Very simple. It is said that the creatinine should be raised by more than 25 micromole per liter from the baseline, or more than 50% rise of creatinine from the baseline, and urine output is reduced more than 50%. So the diagnosis of AKI is the likely diagnosis. Very simple, my dear. So urine output, if it is reduced to less than half, so yes, the diagnosis of the AKI. Similarly, the creatinine is increased more than 25 micromole or more than 50% of the baseline. Yes, that should be considered as AKI. So the definitions of the rapidly progressive glomerulonephritis in the form of crescentic glomerulonephritis, which is the histopathological findings. Yes, the crescent formations, the crescent, there will be the crescent, my dear. You will get the crescents in the different varieties of the crescent. We'll see the crescents. Yes, definitely the crescents, that will be the RPGN, my dear. So in the form of means and also the AKI, that will be the presentations. Yes, my dear doctor, my target is not to go through the details of this word, my dear, but these things will be needed for making the answers correctly with confidence in the scenario so that you can understand. Yes, if you see in the urine that the hematuria, and also you have seen some of the protein and you have seen the hypertension, so consider this is a nephritic syndrome. And if you see that the creatinine is raised within a very short time, and definitely there is the level, so consider as an AKI and consider as an RPGN, means the rapidly progressive glomerulonephritis. One of the important dogma I'd like to describe here, there is the what is RPGN, the causes. Yes, my dear. If I'm writing here, the RPGN caused, RPGN, rapidly progressive glomerulonephritis. The causes, if I'm saying, means what are the important causes, and that is our discussion's important points, my dear. This is divided into the three variety of the group of disorders, my dear. The three variety of the group of disorders. The first variety of disorders, the number one, that is said that ANCA-associated vasculitis. ANCA-associated vasculitis. And also this is said that ANCA-associated vasculitis are classified into the two ANCA, definitely. There is a C ANCA and also the P ANCA associated vasculitis. But mind and listen very carefully. If the rapidly progressive glomerulonephritis means the immune complexes will be affecting your glomerulus, so the number one I have given, or also it is also said that the name, my dear, there is another name, that is the PolyAngiitis. PolyAngiitis. PolyAngiitis means low immune complexes, my dear. Means the low concentration of immune complexes will come forward to damage the glomerulus, my dear. So the another name is the PolyAngiitis. I am giving the low immune. That will be helpful to understand, my dear, later on, the low immune rapidly progressive glomerulonephritis. So this is nothing but the ANCA-associated vasculitis. Once again, these are the C ANCA and P ANCA, my dear. C ANCA and P ANCA, once again, C ANCA for GPA is the single disease, my dear. Just remember. And for P ANCA is an MPA and EGPA. Very close to the disease, the GPA, EGPA, and MPA, my dear. Just write it down. We'll discuss later on each and every disease. Yes, my dear. This is C ANCA, this is P ANCA. Now let's talk about what is this ANCA, my dear? ANCA antibody. A short description I'd like to discuss. ANCA means anti-neutrophil cytoplasmic antibody. So feel that this is the neutrophil. So this is the nucleus, feel it. So yes, my dear. So the C ANCA means this is the neutrophil and this is the nucleus. Now, the antibody against the neutrophil cytoplasm. So cytoplasm of the neutrophil, the antibody against this antibody, that is called the C ANCA, C for central. So feel that the central antibodies are, these are the central antibody. Feel it. Feel that the central cytoplasms are these one. So against this central cytoplasm, the antibody is nothing but the cyanca. But these around the central cytoplasm, yes, the proteinase PR3 enzyme is present. So against this proteinase enzyme, the antibody, we call it anti-PR3 antibody. The another name is nothing but, yes, the cyanca, my dear. Anti-proteinase 3 antibody is nothing but the cyanca. In contrast, the peripheral cytoplasm, once again, the peripheral cytoplasm, feel it, these are the peripheral cytoplasm. This is the peripheral cytoplasm. Yes, this is peripheral cytoplasm. So the peripheral cytoplasm is having the enzyme called the myeloperoxidase. So against this myeloperoxidase, the antibody called the anti-MPA antibody, this is nothing but the another name of p-ANCA antibody, my dear. Fantastic. I am telling PR3 looks like, you see the Prime Minister, definitely Prime Minister is the central. So PR3 is nothing but the Prime Minister is the central. In contrast, the P for periphery is the MPs. Member of Parliament is in the periphery, my dear, so that you can remember. So PR3, the Prime Minister is the central, and periphery is the MPO, so that you can remember the antibody is another name, my dear. So cyanca anti-PR3 Prime Minister central, and P for periphery means the cyanca is nothing but the anti-MPO myeloperoxidase antibodies, my dear. And these are found in these only cyanca or PR3 antibodies present in the GPA, and cyanca is the MPA and EGPA, my dear. So this is all about the first one, as I said, the ANCA-associated vasculitis. I have given again the low immune RPGN. If I am saying the low immune RPGN. Number two, if I've given another variety, yes. If I'm saying the borderline immune, if I have given a name, borderline immune RPGN, if I have given a name, borderline immune RPGN. So this is nothing but the disease is, yes, my dear, the nothing but the disease is GPS, means the Goodpasture syndrome. Nowadays it is called the Goodpasture disease. You can say the GPS or GPD, Goodpasture disease, or the another name is anti-GBM antibody. Anti-GBM disease or anti-GBM antibody disease, whatever you say. So this is all about the GPS. In a small term, we can use GPS, that will be helpful, the GPS. Why GPS? The Goodpasture syndrome, or another name is the anti-GBM antibody. So this borderline immune means the immune complexes will be linear deposit of IgG at glomerular basement membrane. This is the important point here for the GPS. Just write it down, my dear. It will be helpful later on to understand what I'm saying. And the last thought, yes, the last thought, if I'm writing, yes, my dear. The third variety, yes. Third variety. The third variety is an low immune. This is borderline immune. Now I'm telling the high immune. or highly immune or aggressive in nature. Very aggressive immune deposits, RPGN. And high immune and aggressive type, there is associated with the complement activation. So that's why you'll get the C3 level will be arrowed down. And this C4, you can remember the MCGN, especially type 2. And another one is a DPGN, means the diffuse proliferative glomerulonephritis, especially SLE. And another C4, once again, CGN, that is the cryoglobulinemia. These three diseases altogether. A bit of long list of things, my dear. I understand. It's really important, but you must know, my dear, very, very hot topic for the exam that I'm going to discuss. So once again, very simple, my dear. Means I have divided, and also the different books are classifying it in different ways. But yes, I have given three classifications of RPGN. Rapidly progressive glomerulonephritis. Definitely the three categories I have said. The post-immune means the low immune glomerulonephritis or made RPGN, borderline immune, and the highly aggressive immune, my dear. What does it mean? Means that in case of low immune, in that case, this is important. Yes, the immunity will be less. Means the immune complexes will be less in the glomerular basement membrane. Yes, my dear. Means the immune complexes, you will not get any immune complexes in the glomerular basement membrane or near to that. So that's why this is called the post-immune or the low immune. This is nothing but the ANCA-associated vasculitis. And this is C-ANCA for GPA, P-ANCA for MPA and EGPA. So if I'm given number 1, number 2, number 3 disease, and this is number 4, the GPS means the borderline, means the linear deposit a little bit higher than that of the low immune or post-immune. The immune complexes will be very close to the glomerular basement membrane, and that is evidenced by the linear deposits of the IgG at the glomerular basement membrane. This is nothing but the GBM disease or anti-GBM antibody syndrome, or you can say the Goodpasture syndrome or Goodpasture disease, whatever the name might be. The high immune, once again, where the complement level will be arrowed down. In that case, C4, you need to remember the MCGN, mesangiocapillary, the word that you need to know, the capillary glomerulonephritis type 2, and DPGN is the SLE, and also the CGN, once again, that is the cryoglobulinemia. In that case, the C3 level will be arrowed down. So these are the classifications or maybe the RPGN causes, my dear, and that needs the extensive differentiation so that you can make the answers correctly with confidence, my dear. Alright, my dear doctors, now I'd like to go into the deep, yes, my dear, very deep discussions with the differential diagnosis and differential important points of the GPA, MPA, EGPA, and GPS, my dear. These are the 4 important diseases encountered to be examined, my dear, and you need to know them very, very well. Let me start by having some of the good discussions. Yes, my dear. Having a differential diagnosis of each and every diseases altogether. So let me start by asking one important talk, my dear. So I'm writing from here, so just follow me, my dear. One of the important talk is a renal pulmonary syndrome. What I said? Renal pulmonary syndrome. Renal pulmonary syndrome, my dear. So the renal pulmonary syndrome, the word is said that the renal and pulmonary component will be present, my dear. So the renal pulmonary syndrome means the renal plus pulmonary component will be present, my dear. The renal component as the RPGN, rapidly progressive glomerulonephritis, and pulmonary component is the pulmonary hemorrhage. Yes, my dear, just follow me. The renal component, the RPGN, with the pulmonary component, the pulmonary hemorrhage. If the patients present with these type of combinations, the RPGN and pulmonary hemorrhage, you should think about the first diagnosis. Yes, my dear, Goodpasture syndrome. I'm writing the GPS, my dear. What I said? GPS, Goodpasture syndrome. The Goodpasture syndrome, the RPGN will be presented as I say, the rapidly progressive, so AKI, but maybe in the form of nephritic syndrome, or another name is the crescentic glomerulonephritis. So these will be the presentation, and pulmonary hemorrhage will be presented as with the hemorrhage is presented with the hemoptysis. Hemoptysis. And RPGN will be presented with the nephritic syndrome, and AKI, the presentations, my dear. So you should think about the diagnosis, the GPS, my dear, means a Goodpasture syndrome. My dear, listen very carefully. I would like to talk a little bit further regarding the GPS. I'd like to talk a small box for the GPS, my dear. GPS means the Goodpasture syndrome. I'll give a box for the good, or always the man is good. Yes. Yes, my dear. Means Goodpasture syndrome is a disease of the man, my dear. But they are having the DR2, strongly associated with the HLA-DR2, and the new emerging, yes, my dear, is an HLA-DR.2. I'm writing the B1 star 15 is to 1, 1501. Yes, my dear. And the Goodpasture, the restricted, just write it down, restricted, yes, T cell epitope. It's strongly associated with the Goodpasture syndrome. This is the HLA-DR B1 1501 restricted T cell, yes, restricted T cell epitope is strongly associated with the Goodpasture syndrome. Yes, my dear doctor, I'd like to talk. GPS is a very important hot topic for the exam. So G for GPS and G for, this is G for, this is, you need to remember, G for good, or always the man is a good. And G for, once again, GBM antibody, means the anti-GBM antibody. So that's why the disease, another name is the anti-GBM disease or anti-GBM antibody syndrome or disease, my dear. And this GBM antibody is nothing but the IgG linear deposits at glomerular basement membrane. So this is all about all the G's, my dear, that you need to know. Yes, the G for good man, G for GBM, G for IgG, linear deposit in the glomerular basement membrane. Yes, my dear, it's very important. Yes, so all the G's that you need to know. So yes, my dear doctor, let's talk a little bit further. As I said, that the Goodpasture syndrome is nothing but the RPGN, the rapidly progressive glomerulonephritis, number one. and second presentation is the pulmonary hemorrhage. So yes, my dear doctor, the renal pulmonary syndrome. Now I'd like to talk the renal pulmonary syndrome. Yes, the first diagnosis you should think about the RPGN followed by pulmonary hemorrhage. So the pulmonary hemorrhage is not always a feature, but pulmonary hemorrhage risk will be increased in case of young, male, smoker, yes my dear, and having the lower respiratory tract infections. Yes, this is important. And if the patient's having with the pulmonary edema and use of hydrocarbons. So this is the smallest box that will put the risk to develop the pulmonary hemorrhage. What I say, the young male smoker, lower respiratory tract infections, pulmonary edema, and use of hydrocarbons. So very small boxes that you need to know. Sometimes the questions are hitting these, the increased risk of pulmonary hemorrhage in patients with the Goodpasture syndrome. So yes, my dear doctors, a Goodpasture in the renal pulmonary syndrome. Yes, once again, the first diagnosis you should think about in the form of RPGN and the pulmonary hemorrhage. The second differential diagnosis I'd love to tell is nothing but the GPA, my dear. What I said, the GPA, yes, once again, the second diagnosis, the GPA. GPA means granulomatosis with PolyAngiitis. What I said, the granulomatosis is PolyAngiitis. In granulomatosis and PolyAngiitis, the first presentation would be the upper respiratory tract followed by lower respiratory tract involvement. Means in GPA, the first presentation should be the respiratory, my dear, rather than the renal. Respiratory means, once again, what I said, upper respiratory tract involvement followed by lower respiratory tract involvement. Means the first presentation will be the upper respiratory tract involvement followed by lower respiratory tract involvement, the second presentation, my dear. If the upper respiratory tract followed by lower respiratory tract, the scenario say that, please consider diagnosis the granulomatosis with PolyAngiitis, upper respiratory tract involvement, upper respiratory tract involvement in the form of nasal, yes. What will be the happening? Yes, my dear, the nasal involvement in a different varieties of ways, especially the nasal crust, rhinitis, nasal block, yes my dear, and also, yes my dear, the epistaxis, you can write the epistaxis, this is important, epistaxis, and also you can go back the sinusitis, you can go back to the ear, so you can say the earache, you can go back to the ear, once again the hearing loss, means the deafness, even the deafness, and sometimes the nasal crust, rhinitis block, and also sometimes the nasal cartilage effect, so there will be the saddle nose. So many features, and this saddle nose is very typical here, the saddle nose, yes. So the upper respiratory tract involvement in a different varieties of ways. Followed by the lower respiratory tract involvement is nothing but the pulmonary infiltrates, the pulmonary involvement, infiltrates, and also sometimes the hemoptysis, yes, the pulmonary infiltrations and hemoptysis. Means what I'm saying, by the upper respiratory tract followed by the lower respiratory tract involvement, you should think about the diagnosis, yes my dear, the Wegener's granulomatosis, the older name Wegener's granulomatosis. And upper respiratory and lower respiratory involvement followed by, or sometimes both together, the rapidly progressive glomerulonephritis can be presented, and that should be the number 1, this is number 2 lower respiratory tract, and this is number 3 RPGN. So if I'm putting all them together, we can make a box, the GPS, the box might, if you write it down, so yes, this is all about the GPS. And here the Wegener's glomerulonephritis, yes, my dear. This is all about the Wegener's glomerulonephritis. And the next differential diagnosis, the Renal pulmonary syndrome, very close to the GPA, is an MPA, microscopic PolyAngiitis. What I say? The microscopic PolyAngiitis. In microscopic PolyAngiitis, also there is a presentation of RPGN, yes, upper respiratory tract, yes, and lower respiratory tract, yes, my dear. Microscopic PolyAngiitis. Similarly, the another differential diagnosis is an EGPA. Once again, the EGPA RPGN can produce the RPGN, and also the upper respiratory tract, and can also the lower respiratory tract, the involvement. Now the question, how to differentiate in between these four important disorders is very difficult. Yes, let's discuss a little bit further. So once again, as we talk about the box says here, yes, for the MPA and EGPA, how to differentiate? For the EGPA, the E for eosinophilia. The most important differentiating points for the EGPA is an eosinophilia, which will not be present here, which will be not be present here, which will be not be present in case of GPS as well. If you write down, yes, my dear. So if I'm putting out these things all together, so then we can write down, yes, my dear. Yes. So once again, if you write down here, so this is absent. Means the eosinophilia is an important point for the EGPA to differentiate. That's why the name itself is an EGPA, eosinophilic granulomatosis with PolyAngiitis. The pathognomonic pictures in the eosinophilia is that should be more than 10%, my dear. What I said? The 10%. The previous name of EGPA is Strauss syndrome. I'll discuss further a little bit, but yes. Yes, my dear. Now that the differentiating points that you said, the eosinophilia, now how to differentiate other things, my dear? The GPS and the GPA, MPA, and EGPA, we already learned the GPA, MPA, and EGPA are ANCA positive vasculitis for the development of RPGN, my dear. RPGN, yes. So these RPGN, of course, this is called the ANCA or post-immune or low immune variety of vasculitis, means the low immune RPGN. So GPA, how to differentiate? In GPS, the antibody, we call it anti-GBM antibody will be positive. In contrast, in case of GPA, there will be the CANCA, yes. In case of MPA, there will be the PANCA, and in case of EGPA, once again, PANCA positivity. So the antibodies are CANCA, PANCA, and PANCA. And also, if you do the in GPS, RPGN, the biopsy, if you do the biopsy in GPS, you'll get the linear deposit of IgG at glomerular basement membrane. Definitely. In Wegener's granulomatosis is a very important matter. It's a necrotizing small vessel vasculitis. Yes, my dear. So you can say this is a Wegener's granulomatosis. So this is granulomatous. So granuloma will be present. There will be no granuloma. Yes. And there will be the eosinophilic deposition. The differentiating points. So these are the very differentiating points in between these three important diseases, my dear. To differentiate in between this Cianca positivity, granulomatous PolyAngiitis or granuloma, and this is a Pianca for the MPA, and also there will be the no granular, because the name itself says that MPA, microscopic PolyAngiitis, and this is the Pianca and the eosinophilic infiltrations, my dear. So I'd like to summarize a little bit so that you can differentiate, my dear. Knowing these boxes, my dear, it will be helpful to clinch the diagnosis and to differentiate from each other. So let's talk a little bit further. So the Goodpasture syndrome, as I say, the renal pulmonary syndrome is a 5-star topic, my dear. Renal pulmonary syndrome is a renal and pulmonary, renal-pulmonary, in the form of RPGN, yes, my dear, and pulmonary hemorrhage, as I said. Yes, my dear. This combination, the first diagnosis, think about the GPS. In contrast, GPA is just reverse what I said. The pulmonary component with the upper respiratory tract followed by lower respiratory tract, then the renal involvement. And next is the MPA, very close, very similar. But the next one is the EGPA, is the eosinophilia, is a single important points to differentiate, my dear. And definitely the antibodies will helpful to differentiate in between this Cianca, Pianca, and there is a linear deposits, yes, my dear, the IgG deposits in the biopsy that will not be present here, rather than we'll get some of the granuloma. Here will be non-granulomatous, means no granuloma. Here will be the eosinophilic depositions, my dear. So these are the important points that you need to know, my dear, to differentiate from each other. Another box, as we said, the GPS is nothing but the anti-GBM antibody syndrome, means the Goodpasture syndrome. If you know them, it's really another important box that I'd like to add here, the GPS. Yes, my dear. So yes, my dear doctor, so the GPS treatment box, I'd like to add G for, just write it down, glucocorticosteroids, and P for plasma exchange, and S for, all right, cyclophosphamide. You can write down the cyclophosphamide. Means whenever the RPGN, then you should start with the glucocorticosteroids and cyclophosphamide all together, the diagnosis, my dear. So the glucocorticosteroids, once again, glucocorticosteroid, plasma exchange, yes, and cyclophosphamide. So glucocorticosteroid, plasma exchange, cyclophosphamide, GPS to be remembered. So what do you need to do? The plasma exchange equal to the P for plasma hemorrhage, or you can write down here the plasma hemorrhage equal to the plasma exchange is the treatment of choice. So it's an important box, my dear. So that will be encountered in your exams. Whenever the plasma means the plasma exchange means the pulmonary hemorrhage, my dear. Just remember, pulmonary hemorrhage, the only indication is that where you need to do the plasma exchange, my dear. In the form of hemoptysis, the patient will present, my dear. So this is the differentiating points that we learned to differentiate for this, the long list of disorders altogether. So yes, my dear doctor, I'd like to add some other important features that will be helpful to differentiating these diseases. And the diseases, as you say, the renal pulmonary syndrome, the number one disease that you should think about the GPS, number 2 is the GPA, number 3 is an MPA, and number 4 is an EGPA. I'd like to talk a little bit further regarding the EGPA, small boxes that I'd like to add. So yes, the EGPA, the Shastro syndrome, the box that you need to write down, don't charge me as Priyanka. All right, Priyanka Chopra, yes. It's a very famous heroine of the Bollywood, yes, Priyanka. Just to remember log, a smile. So these are very important mnemonics and the lines minded to remember all the diseases all together. So that will be helpful to remember. Don't charge. Charge means the Shastro syndrome. Me for M for mononeuritis multiplex, and E for eosinophilia, and S for the asthma. You can write down. And Priyanka means the P-anka positivity. And this is don't and this is lol. This don't lol, it does mean that don't use the L-TRAS in a patient with the Shastro syndrome, because the L-TRAS can precipitate the asthma attack in a patient with the Shastro syndrome. So yes, my doctor, you need to know that these Shastro syndrome having some of the important features. As I said, the Shastro syndrome, don't charge me as Priyanka Chopra. So don't charge me as Priyanka Chopra will be helpful to remember that it is asthma. The don't charge means the Shastro syndrome. Me for M for mononeuritis multiplex, E for eosinophilia, yes, my dear, is for asthma and Priyanka, and also the lol, there's a don't lol. So yes, my, the diagnostic criteria, you say that the 4 out of 6 criteria, if it is fulfills the diagnosis of the EGPA. So we can write down the EGPA once again equal to bronchial asthma with eosinophilia is the most important part of the diagnosis. It means the EGPA disease actually passes through the 3 important stages. Asthma phase, first one, eosinophilic phase, the second one, and third phase, the vasculitic phase. So asthma, eosinophilia, and third one is vasculitic phase, my dear. And these vasculitis in the form of mononeuritis multiplex, my dear. And also other symptoms and other variety of the symptoms. And definitely that the, as you say, the Priyanka positivity, another important point. And of course, the sinusitis means the upper respiratory tract infection, sinusitis, and pulmonary infiltrates. So these are the 6 important features that you need to know whenever the more than 4 criteria makes the diagnosis likely for EGPA myasthenic Shastro syndrome. As I say, the EGPA, as I say, the bronchial asthma with eosinophilia. Next is the mononeuritis multiplex in a variety of multiple areas of the nerves will be involved. Right, the right wrist is dropped and the left leg is weakness. So the mononeuritis multiplex, mononeuritis means the mononerves will be affected, yes, by the vasculitis, means the small vessel involvement that supplying these nerves. This is a vasa viscera or vasa nervorum, right? And this is the Priyanka positivity and sinusitis and the pulmonary infiltrates. So these are the 6 important features for the EGPA to make the diagnosis, and definitely to differentiate. Along with that, that can be the RPGN, means the renal involvement in the form of the vasculitis that can cause, and also the upper respiratory tract for in the form of sinusitis, lower respiratory tract, the pulmonary infiltrates, as I said. Yes, my dear, and the Priyanka positivity, there's the differentiating points, my dear. So yes, my dear doctor, I'd like to go now into the scenarios. Now we'll apply these knowledges that you learned from here. Starting from here, now RPGN needs a kind, crescentic glomerulonephritis, and the presentations, the RPGN, the 3 varieties of the diseases to differentiate all them together. So let's get back into the full scenarios. Just a little bit reminder that the disease that you already learned, but here the high immune aggressive, the C3, my dear, C3, you just remember the hypocomplementemia. There is a C3 will be low down, at least a single disease that you need to remember. There is a MCGN, as I said, and also the SLE. Yes, the SLE, the DPGN, diffuse proliferative glomerulonephritis, and the cryoglobulinemia is a separate chapter that I'll discuss, my dear, these diseases. But at least that you need to know low C3 level, my dear. And after that, this is the scenario that the next box that we learn for the renal pulmonary syndrome, the Goodpasture syndrome, the renal pulmonary, the GPA, GPA, MPA, and also the EGPA, the differentiating features altogether, will now apply into the scenarios. Let's enjoy the scenarios, my dear. Now, my dear doctor, let's start and also apply our knowledges that we already learned from the board lectures into the scenarios. Let's get back and do it swiftly as early as possible so that we'll be able to make the answers correctly with confidence. Here is the rapidly progressive glomerulonephritis, RPGN, the terms used to describe the rapid loss of renal function as well as the formation of epithelial crescents, as I said, in the majority of the glomeruli. Causes are, as I said, the Goodpasture syndrome, Wegener's granulomatosis, and also other features. Yes, the nephritic syndrome, as I said, in the form of nephritic syndrome, the hematuria with the red cell cast, proteinuria, and also the hypertension and oliguria. As I said, the more equal to, there is a hematuria, hypertension, or hypertension, hematuria, along with the oliguria and sometimes the proteinuria and sometimes the AKI. Specific features like the hemoptysis for the Goodpasture's, vasculitic rash or sinusitis for Wegener's granulomatosis. Here are the features for the glomerular full of crescents. You see the full of crescents are full of crescents here, the full of crescents here. So yes, these are the crescents. Yes, my dear. So the next another crescents, you see the crescents are, these are nothing but the aggressive formation of the crescents that are damaging the glomerulars that lead to the crescentic glomerulonephritis, and the name of Wegener's means the RPGN, my dear, rapidly progressive glomerulonephritis. Let me start with a question here. The question number 1, there is the granulomatosis with PolyAngiitis. From these information, which of the following conditions is the most likely? Pneumonia, granulomatosis, PolyAngiitis, SLE, Goodpasture, Shastra syndrome. Let's start with the question scenario. Means we always read from the main question, my dear, starting with that, and after then answer options, and then get back to the scenario down to up. So a 25-year-old man presents with a hematuria, fever, vomiting, and fatigue. He has a creatinine, circle the creatinine, 342, and having previously had a creatinine 95 when it was last checked 2 years back. In the emergency department, he coughs up a small amount of bloody sputum, then has a nosebleed. So nosebleed is nothing but the epistaxis, means this is upper respiratory tract involvement, followed by the bloody sputum, means the hemoptysis, means the lower respiratory tract involvement, along with the renal involvement. RPGN, in the form of RPGN, is nothing but the diagnosis granulomatosis with PolyAngiitis, means, my dear, Wegener's granulomatosis. Very simple scenario and very important. Say the presence of upper respiratory tract, science points towards the diagnosis granulomatosis with PolyAngiitis. Say that upper respiratory tract, nothing but Wegener's granulomatosis, or yes, my dear, GPA is the likely diagnosis. Yes, my dear, here the patient has an acute kidney injury, fever, upper respiratory tract signs, the presence of the upper respiratory tract ENT signs points towards the diagnosis GPA, previously called the Wegener's. A patient with a Goodpasture is likely to present the hemoptysis, but would not be expected the ENT signs. Why not? This is the GPA. The Goodpasture syndrome, only the renal pulmonary syndrome, there will be no upper respiratory tract involvement, my dear. Means there are epistaxis on earache, other ENT signs, GPA, including crusting, as I said, the nostrils, sinusitis, sinus pain, hearing loss, blocked or runny nose, as I said, my dear. Next, question number 2. Once again, what is the most likely diagnosis? Mixed cryoglobulinemia, Shastros, GPA, hemolytic uremic syndrome, and henoxal and purpura. So if you get back once again up, so as I said, the GPA, if you write down the GPA, Shastros is an EGPA. So these are differential to each other, not this hemolytic, not this henoxal and purpura. And mixed cryoglonemia, as I said, the cryoglonemia, but that are different. That should be the C3 will be arrow down, at least the C3. Means in the questions, whenever you are dealing with the questions, you need to read the main questions, and after that the answer options, and after that the SS boxes that you learn. Let's start with the urine district, the hematuria. Urea creatinine is very, very high. Yes. Next is the ESR is high, WBC is high, inflammatory markers, and platelets is high, is also inflammatory marker, and hemoglobin is low. This is also all are inflammatory markers, is raised. 47-year man, history of chronic sinusitis, means the upper respiratory tract involvement, with shortness of breath, means the lower respiratory tract involvement. Yes, with the emergency department, initial investigations revealed that the urea and creatinine and the hematuria means the RPGN, yes, means the AKI, means the nephritic syndrome. So this is nothing but the diagnosis. The GPA is the likely diagnosis until proven otherwise, my dear. So the combination of the pulmonary, renal, pulmonary combine the history of the chronic sinusitis, means the upper respiratory tract, GPA is the likely diagnosis. Next, coming back to the another questions, you see that what is the most likely diagnosis? EGPA, yes. Microscopic means the MPA. Another one is the PAN, yes. And the rheumatoid arthritis, granulomatosis, and the GPA. So all the GPA, MPA, EGPA, the three differential diagnoses are here. Let's talk. 44-year-old man presents the rhinitis, asthma, tender subcutaneous nodules, antibodies to the MPA ANCA are present in his blood. So MPA means the P ANCA. As we already learned, the P ANCA positive diseases are nothing but the two diseases, only MPA and EGPA. And my dear, already we learned that EGPA is the only disease where the asthma is described in the differential diagnosis. So asthma with eosinophilia. So definitely you can think about there is an asthma and the upper respiratory involvement, the rhinitis, and also the subcutaneous nodules of vasculitis, and here the eosinophilic count, yes, once again. So asthma with eosinophilia is a likely diagnosis, EGPA, my dear, and PANCA positivity, once again, the EGPA, upper respiratory involvement, PGPA, and also actually shows the pulmonary, the patchy pneumonitis. As I said, the asthma, eosinophilia, and once again, the mononeuritis multiplex, my dear. As I said, the asthma, eosinophilia, mononeuritis multiplex, yes, my dear, the diagnosis is the likely diagnosis. And next is the PANCA. So you got the asthma, you got the eosinophilia, you got the number 3, the upper respiratory tract. Yes, this is another point, the upper respiratory tract involvement, rhinitis, sinusitis, yes. And number 4 is the patchy. The 4 criteria out of the 6 criteria that you found make the diagnosis. The EGPA is the likely diagnosis. Definitely it's not in MPA, it's not in PolyAngiitis nodosa, it's not other disease, my dear. So the next question, once again, yes, my dear, the next question I'd like to go, which of the following is the most likely diagnosis? Once again, the Shastra syndrome is the EGPA, microscopic PolyAngiitis MPA, SLE, and GPA. So if you get back from down, C3, C4 low means the normal. Normal means definitely the SLE is excluded. Done. PANCA positive. So once again, PANCA positive, definitely GPA is not the diagnosis. Now in our hands, the EGPA and MPA is the likely diagnosis. Very simple. So PANCA positive, EGPA and MPA. Now the urine, proteinuria, white cells, red cells. So once again, you got the glomerular manifestation. So 182 creatinine is high, potassium is likely high range, and platelets, white cell, and hemoglobin is low, the inflammatory markers. Now 45-year-old woman presented in rheumatology clinic. She has suffered fevers, malaise, joint pains. Yes, fever, malaise, joint pains. Yes, my dear, these are the muscle aches. These are nothing but the vasculitis, my dear. The few months which are increasing in severity, she has also suffered from a skin rash. So I'm telling my dear, the fever, rash, arthralgia, and the malaise. If you say the malaise, fever, rash, arthralgia, malaise, fever, rash, arthralgia, malaise, the frame is nothing but the vasculitis common manifestations, my dear. If I'm saying the vasculitis, you will have the chances, the fever, rash, arthralgia, malaise, fever, rash, arthralgia, malaise, fever, rash, arthralgia, malaise, the frame, my dear. So you can say, yes, my dear. So you see the skin rash, also suffer skin rash, past 6 weeks, other past history of over the past 6 months include the 2 episodes of mononeuritis. This is important. Affecting the left common perineal and also the right facial nerve, mononeuritis multiplex, you see, and there are here the palpable purpura on the trunk and livedo reticularis affecting both the legs. So this is a very important diagnosis, my dear. Yes, this is said that microscopic PolyAngiitis, because as we say the Pianka positivity, yes, the joint pains, fever with the dark microscopy is the 60% Pianka and after 40% Cianca. Glomerulonephritis MPA is characterized by focal necrosis, crescent formation, absence or least paucity of immunoglobulin depositions, my dear. So, my dear, listen very carefully. Definitely, it's not an EGPA. As we say, the Pianka positivity, the 2 disease in our hands, that is the MPA, and second disease is the EGPA. But EGPA in here is the asthma is the first important point. So, asthma is not there. Eosinophilia is not there. So, yes, the other things are there, the Pianka and other criteria. But yes, the likely diagnosis that should be in case of EGPA, that should have essentially asthma phase, followed by eosinophilia, followed by. So, there is no eosinophilia in the white cell count, no specific things. So, the next diagnosis is the MPA, microscopic PolyAngiitis. So, the renal involvement, yes, my dear, along with the mononeuritis multiplex, along with the other vasculitic features, is the likely diagnosis of microscopic PolyAngiitis. Microscopic PolyAngiitis diagnosis, you should exclude the other diagnosis before getting a microscopic. It means they exclude the GPS, exclude the GPA, and then come back to the microscopic PolyAngiitis. It's very important tips and tricks. The question number 3, once again, which of the following is the most like a diagnosis? The different answer, but yes, once again, the Behçet's disease, SLE, here is the GPA, that's why this comes. And the PAN and also ulcerative colitis. The creatinine is good, potassium is good, CRP is high, platelets and hemoglobin is low. So this is once again the variety of vasculitis. Yes, the 30-year-old man presenting man managed by the ophthalmologist, the anterior uveitis, is referred to the opinion he is now suffering the painful genital ulcers and rash, which resembles the erythema nodosum. For example, he has an oral leptin ulcer and ulcers on his scrotum. Another history includes the diarrhea. GP thought he was irritable bowel syndrome. So yes, my dear, so this is nothing but the Behçet's syndrome or Behçet's disease. We call it the 3 U's, my dear. Means the U for ulcer, U for ulcer, and U for uveitis. These are the syndrome, minus the separate lectures, but at least you need to know the Behçet's disease is nothing but the ulcer uveitis. So this is orogenital ulcers with the uveitis, the diagnosis of the Behçet's syndrome rather than any other diagnosis. Why this is here? Because the Behçet's disease is also a vasculitis, but this is no ANCA, small vessel vasculitis. Non-ANCA means no ANCA associated. Non-ANCA associated vasculitis, small vessel vasculitis. So here's the next one is the 4. The question number 4 is here. Yes, my dear, this is the which of the following is the most likely diagnosis. Here is the Alport syndrome is the different, but the question scenario is having the GPA is the likely differential diagnosis here. Why? And also the SLE, post-traumatic IgA nephropathy post, but we can go the 18-year-old woman has recently been referred to the ENT surgeons for the deafness. Because the deafness is causing also in the GPA, so that's why it comes to the clinic complaining of the pink-stained urine, and she's concerned that she's losing blood into her urine. She has recently suffered respiratory tract infections. Recently suffered respiratory infections. So recently suffered respiratory infection means the infectious. Apparently, her brother was 21 and also more serious hearing loss. So this is also a history of family history. So this is familial disorder. And on examination, her blood pressure is 135/72, pulse is regular, general physical unremarkable unit test is the 2+ hematuria and also 1+ proteinuria. Creatinine is here. So my dear, listen very carefully. So young people having the deafness, yes, with the family history of deafness, once again with the glomerular disease in the form of hematuria and proteinuria, and light, some high, about 130, slightly pre-hypertension, hematuria, proteinuria, pre-hypertension. So all are glomerular disease. So definitely you should think about the APPROACH syndrome rather than anything else, because the granulomatosis PolyAngiitis needs the upper respiratory tract followed by the lower respiratory tract should be here, but this is not here. So the different diagnosis definitely is not a diagnostic GPA rather than this APPROACH syndrome. And next is what is the most probable diagnosis here is the GPA, GPS is here, and also the GPA and MPA. So very good differential diagnosis, are 3 diagnoses and other pan and tuberculosis. Urine analysis showed the blood and protein, means hematuria proteinuria, and patchy interstitial shadowing. Yes, the urea creatinine is very, very high, potassium is high, definitely is an AKI, no doubt. AKI leads to the high potassium along with the high creatinine and urea levels. Platelets is high, hemoglobin is low, and WS is all are inflammatory markers. Vasculitis 37 year, present to the emergency, 2 weeks history of the hemoptysis. So this is important. And red colored urine. She had a similar problem 2 years back, but recovered fully and suffered from the intermediate of sinusitis. So sinusitis means the upper respiratory tract involvement followed by hemoptysis, lower respiratory tract involvement. Once again, diagnosis is a GPA until otherwise proved, my dear. So once again, you got the GPA along with the renal involvement with the, once again, we got the RPGN as the likely diagnosis. The GPA is the likely diagnosis. Here, which is one of the following the vasculitis more often associated with the renal involvement. This is important. More often involved with the renal, here is EGPA. As I said, the EGPA is nothing but first one is the bronchial asthma with eosinophilia, and then mononeuritis multiplex. So later on is the kidney involvements. Yes, my dear. Here is a triangular vasculitis, henoxolin purpura, and also the Takasar is a large vessel vasculitis. But here we have the microscopic PolyAngiitis. This is one important talk. The microscopic PolyAngiitis can cause RPGN. Of course, the EGPA can cause, and also the GPA can cause. This is important. Renal is equally common in the GPA and also the MPA, my dear. Means the microscopic RPGN. So in terms of RPGN means the GPA and MPA, my dear, is the disease rather than EGPA. Yes, my dear. Next question, you see the 35-year-old man presents with a cough, hemoptysis, glomerulonephritis. So once again, the renal pulmonary, he is a long-term smoker. His cyanca levels are elevated. So renal pulmonary syndrome, cyanca positive, cyanca is a single disease, my dear. Go for GPA is the likely diagnosis. Next, mind the questions you see that which one of the following is the most likely cause of the kidney disease? Kidney disease cause, my dear. So yes, of course, here you see the different diseases: acute tubular industrial nephritis, lupus nephritis, membranous glomerulonephritis, obstructive ureteritis, and microscopic PolyAngiitis. So definitely microscopic PolyAngiitis, the renal involvement is more, my dear, and also the GPA as well. So you can start the 56-year-old woman presents with the aching joints and non-specific malaise and weight loss, 3 months. Her blood pressure is 180/100. So yes, and she has a mild peripheral edema and dipstick analysis, the evidence of hematuria and proteinuria. So this is a glomerular disease. Her serum creatinine is 367, whereas 6 months earlier it had been a normal, but the 3 months earlier, so this is important, 148 to 367. So definitely this is AKI, means the AKI. Yes, my dear. AKI means the RPGN. And our family doctor had 1 week previously prescribed the diclofenac sodium for her joint pain. Only 1 week previously, but the 3 months, within the 3 months, that jumped up. So definitely this is not due to the diclofenac. The complement test, the C3 level is normal, C4 level is normal. So C3, C4 normal, it does essentially mean that the lupus nephritis is out and the diclofenac is only the last 1 week. For the acute tubular interstitial nephro-obstructive idiopathy, there is no chances, and there is no chances for the membranous glomerulonephritis as well. There is nothing is there. So definitely the microscopic PolyAngiitis is the likely diagnosis for RPGN, because the RPGN is caused by GPA, MPA, GPS, or maybe the EGPA is the least likely possibility. Fourth differential diagnosis of this scenario. Next, coming back to the another scenario, my dear, we are getting back. Yes, my dear, very, very important. The another questions. So which of the following is the most likely diagnosis? Is said that the different variety. You see the MPO and NR positive. So MPO means the Pianka positivity. So Pianka positive, the two disease, the MPA, once again the EGPA. So very simple. So definitely here you see the microscopic PolyAngiitis, and there is nothing. EGPA is not here. So definitely the MP is the likely diagnosis. MP is answer. You see within 2 seconds that you make the diagnosis, just knowing these facts, but you can get up. So ESR, CRP is raised, creatinine, potassium is high, 104 hemoglobin, WBC, and also the inflammatory markers. On examination, blood pressure, pulse, you are note the libido reticularis, purpuric rash affecting the both legs, regional auscultation of the chest, oxygen saturation is low. 49-year-old woman referred to the emergency department to worsening renal function, and 2 episodes of hemoptysis, renal pulmonary syndrome over the past 24 hours. She has been seen on a number of occasions by the GP and fever, arthralgia, rash. So once again, yes, my dear, the frame, fever, rash, arthralgia, and also malaise for the first 4 months. She takes no regular medications, having the vasculitis, having the Pianka positivity, having the rapidly RPGN, so definitely diagnosis, microscopic PolyAngiitis is a likely diagnosis. Shasta syndrome, as I said, the EGPA, the different features, my dear, we already know them, we already discussed. Yes, my dear. Now get back once again, which one of the following antibodies is most likely to be present. So once again, you see the 41-year-old past history of asthma, with the pain and weakness in the left hand, and examination findings consistent with the left heart palsy, blood test, eosinophilia. So asthma, eosinophilia, diagnosis EGPA, along with the mononeuritis multiplex in the form of weakness in the left hand, and also left ulnar palsy, mononeuritis multiplex. So the Pianka will be positive in EGPA is the likely diagnosis. Question number 2, once again, which antibody is the likely diagnosis? So the antibodies are there. So once again, if you get up, so CRP is high, urea creatinine high, and once again, if you get up, so WBC is high, and the eosinophilia. So whenever the eosinophilia is high, so claims the diagnosis EGPA, so definitely the Pianka should be positive. So the answer is the Pianka. You see, you don't need to get up, but yes, with a short, brief reading mind that will be helpful, that due to extensive petechial rash on the lower legs the last 2 weeks and has minimal past medical history other than asthma and eosinophilia, once again the nasal polyps, upper respiratory tract involvement. Yes, my dear, the asthma, eosinophilia, EGPA, Pianka is the likely diagnosis. And the answer, my dear, which one of the following most likely cause of the kidney disease? Once again, there is a variety of the disease you see. So now if you get up, so C3, C4 normal, is a similar joint aches, so hypertension, proteinuria, hematuria. Once again, the RPGN, yes, my dear, definitely the diagnosis, microscopic PolyAngiitis. If you get back the another scenario, once again, yes, which one of the following is the most likely diagnosis if you get back once again? So if you see the hematuria and the respiratory function test, the KCO, my dear, KCO increase mean, KCO, just write it down, increase means the pulmonary hemorrhage. Raised KCO means the pulmonary hemorrhage. So once again, the Renal pulmonary syndrome, chest X-ray bilateral infiltrates, and the creatinine is very high, WBC high, hemoglobin low, the inflammatory markers are raised. So once again, the 42-year presents in the emergency, rapidly worsening shortness of breath over the past 24 hours, cough productive. So the productive blood stain smoke, and she smokes the 5 cigarettes per day, medications, progesterone on the pill. Further questioning, she tells you that problems with increasing fatigue over the few weeks. She is consulted GP previous occasions because of the sinusitis. So upper respiratory tract, lower respiratory tract, once again, the GPA is a likely diagnosis, the granulomatosis, the PolyAngiitis. So get back to another scenario that which one of the following pathogenic features has led to the renal lesion? It's a very important topic. So it's a very pathogenic features has led to the renal lesion. So get back. Here are the different things. So can you get up here? The 19-year-old woman complains the stiff joints, facial rash. Young female with the rash, facial rash with the joint pains. The diagnostic SL is the likely diagnosis. Blood pressure is high, edema, and the swollen metacarpophalangeal joints and some ulceration of her buccal mucosa. So definitely SL is the likely diagnosis. EGFR 86 and 89 and platelets is 92. So there is a bicytopenia, urinalysis, hematuria, proteinuria, high titers, double-stranded antibody are detected in our serum. So this is definitely the SLE, definitely minor, but the most common, you need to know the SLE affected the 0, 1, 2, 3, 4, 5 stages, my dear. So among them, the SLE, the grade 4, the most common, we call it the DPGN, that is the diffuse proliferative glomerulonephritis. In that diffuse proliferative glomerulonephritis, you'll have the impulse of chances to get the subendothelial deposition of immune complexes. So this is the things that you need to remember. The most common variety is the DPGN, diffuse proliferative glomerulonephritis, means the proliferation of the glomerulus, including the mesangium and also the glomerular basement membrane. So it is said that the subendothelial, yes, my dear. So the type of the renal disease that develops the systemic SLE is dependent on the site of deposition of the immune deposit, which may in turn be dependent on the site of immune complex formation. So this is important. The circulating immune complexes tend to be large, yes, anionic, and cannot cross the glomerular basement membrane and thus become deposited between the vascular endothelium and the glomerular basement membrane. That's why the subendothelial. All right. So yes, my dear doctor, listen very carefully. As I said, if the immune complexes are large and anionic, so large and anionic, that will not be able to cross the glomerular basement membrane, and that will be remained on the glomerular basement membrane and also the endothelial junction. So that's why this is the deposition in the subendothelial junction. That's why I said that in DPGN, the subendothelial word, my dear. These complexes are efficient at fixing the complement, thereby generating chemoattractants such as the C3a, CBA, which have the direct access to the circulation, resulting in the influx of the immune effector cells such as the neutrophils and mononucleotides. Means in DPGN, you'll have the chances C3 will be eroded. In contrast, there is another changes. Yes, my dear, this is important. You see, these changes are called manifest histologic and mesangial and proliferative glomerular, means the diffuse proliferative glomerulonephritis clinically by the nephritic syndrome. Hematuria is prominent feature, means the nephritic syndrome. Means the DPGN will be presented as the NEES, my dear, nephritic syndrome, hematuria, hypertension, proteinuria, oliguria, something like that, nephritic syndrome. So that are formed in situ and deposit GBM in the epithelium, Bowman's capsule. So this is important, my dear. Yes. And clinically by the nephritic with them prominent. Now the immune complexes that are formed in situ that are cationic, this is important. In contrast, the anion, to deposit in between the GBM and the epithelium, Bowman's capsule, there is the subepithelium. These are also capable of activating the complement, but the presence of the GBM between them and the circulation prevents the free diffusion of chemoattractants and influx of the calculated effective cell. Thus, the urine sediments is bland, this is important, with little or no hematuria, although proteinuria may be massive. So if I say a very short descriptions of the two important TOC miter in SLE, if I'm writing in SLE, the two varieties of the things that you'll get miter. Definitely the most common is the DPGN, and another one is the MGN miter, means the membranous glomerulonephritis. In SLE stages that you'll see that the type 4 is a DPGN and type 5 is the MGN miter. So as I say, the DPGN is the most common. So in that case, the C3 level will be arrowed down. In case of MGN, the C3 will be normal miter, means the complement level will be normal. And the most importantly, as the DPGN, diffuse proliferative glomerulonephritis, that leads to the subendothelial. In contrast, this is subepithelial. As because the glomerular basement membrane is a barrier, that's why the C3 is normal miter. And most importantly, because of the subendothelial deposition here in the DPGN, so in DPGN presenting is the niece miter, nephritic syndrome is the hematuria, hypertension and proteinuria. In contrast, in case of MGN, membranous glomerulonephritis, that you'll get the proteinuria, little or no hematuria. That's why the urine sediment is a bland sediment. So the bland sediment miter. So these are the differentiating points in between these two diseases altogether. Yes, miter. So in case of SLE, as I say, the DPGN is the most common, so that's why you need to know the DPGN only. DPGN having the subendothelial, in contrast, this is the subepithelial, and the DPGN having the C3 will be low, in contrast C3 will be normal, and this is the presentation of the nephritic syndrome, hematuria. So the scenario here, the most common variety is the subendothelial, they say which of the following is the pathogenic features is a subendothelial rather than other things miter. Subendothelial depositions miter. Rather than if you see that this is a deposit, linear dense deposit is not that it is circulating antibody directly against the glomerular, no, the anti-GBM antibody syndrome, and IgA is the IgA nephropathy, the separate disease. 43, the another question is which of the following is the most like a diagnosis, say the pneumocystis carinii or GVC pneumonia. Why? If you get back up on the chest X-ray, perihilar fluffy opposites, LDH is high, and creatinine, potassium, platelets, and having some hemoglobin is low. And if you get a 32-year-old man comes to the emergency department for review, the progressively increasing shortness of breath and dry cough. What? The 32. So miter, listen very carefully. The man, the sexually active active man, his exercise tolerance is significantly reduced, and he is only able to walk for a few meters around his house before he gets short breath. He has a past medical history of the hemophilia. Hemophilia, the word is to say the hemo means blood, philia means love. Loving for the blood miter means he needs the blood. So he has been going through the blood transfusion in the southern Italy before moving to the UK some 4 years back. So having some of the blood transfusion, that likely to be a chances to get the infected by the HIV is, yes, my chances. That's why the Italy, they say the southern Italy. On examination, his BP is normal, pulse regular, he has some white plaques in his tongue, white plaques inside his mouth as well. So it can be the candidiasis, or maybe the oral candidiasis, or maybe the possibility immunosuppression. Yes, my dear. And there are scattered crackles and wheezes and auscultation of the oxygen saturation measured by pulse oximeter falls to, so to get him to walk. So this is called the exercise-induced desaturation. Exercise-induced desaturation is a clinical features at the bedside diagnostic test for the PCP miter, pneumocystis carinii pneumonia. Is a box that you need to remember. And this is the diagnosis of hemophilia A raises the possibility this patient has been previously exposed to the inadequately screened factor VIII. Yes, miter, leading to the HIV infection. And that is the TOC miter you need to know. The wide oral plaques, the candida infection, the immunocompromised, in turn, the desaturation, minimal exercise, dry cough, LDH, perihilar darkness, chest X-ray, fifth, the diagnosis, the pneumocystis kind of pneumonia, the organism is confirmed with the detection of PCP, sputum sample, or maybe sometimes a bronchial wash that leads to a silver stain that leads to the cyst miter. Detection of the cyst, the co-trimoxazole is the treatment. There's another chapter that will be the answer. Why this is the pneumocystis kind of pneumonia is the differential diagnosis here. Yes, because of the EGPA. So once again, EGPA needs definitely the bronchial asthma rather than anything else, and also the eosinophilia. But there is no bronchial asthma and eosinophilia to differentiate here the diagnosis. Which of the following is the most likely diagnosis? EGPA, so you see the Goodpasture syndrome and also the SLE and here the GPA. So a very good differential diagnosis. So let's get back from the down to the hematuria, proteinuria, patchy pulmonary infiltrates, ESR, raised in potassium and sodium and eosinophils. Yes. So once again, having the eosinophilia, the EGPA is the likely diagnosis, no doubt about it, and the WBC count and hemoglobin is slightly low. Yes, my dear. 42-year-old man, respiratory clinic, the poorly controlled asthma. So asthma with eosinophilia, the diagnosis is definitely the EGPA, my dear. So cleanse the diagnosis fast. Despite the therapy, the high-dose steroid and montelukast, he is using a salbutamol inhaler up to the once every 10 days, taking multiple puffs per day and waking up to the 3 times per night because of the coughing. And he has also problems with the sinusitis. Once again, you've got another features. And far responded to intranasal corticosteroids. On examination, BP is 135, slightly high. And there is a quiet wheeze on the auscultation of the chest. You note the libido reticuloris vasculitic feature. So once again, the EGPA is a likely diagnosis. Which of the following investigations most likely confirm the diagnosis? Of course, here is the answer is serology for the Aspergillus specific IgG. Why? Because the other differential diagnosis is likely diagnosis here. 52-year normally controls the asthma and shortness of breath and wheeze, nocturnal cough and coughed up with the blood. He also complains of the feeling generally unwell in the headaches and fever. The blood reveals elevated eosinophil count, only elevated eosinophil count, and serum immunoglobulin IgE. That is 1200 micro. This is important. And X-ray reveals the infiltrates in the both lungs. So my dear, one of the box that I'd like to give you, the bronchial asthma plus eosinophilia, the single diagnosis definitely EGPA, the first diagnosis, APPROACH, and second one is the APPA, and say the APPA. Yes. So the two differential diagnoses, the bronchial asthma with eosinophilia, the two differential diagnoses, one is the EGPA and second one, of course, the APPA. But once again, the EGPA needs the other differential diagnosis, the other things might, at least the mononeuritis multiplex, if you write down in the bracket, and APPA needs the allergic, the word might, the allergic bronchopulmonary aspergillus. So allergic word equal to A for asthma plus eosinophilia plus IgE will be very, very high. This is the differentiating point. IgE will never be the high in case of EGPA miter. So here is the IgE is high, so definitely the diagnosis APPA, that is the differentiating points from the EGPA means the Shastov syndrome. Of course, bronchial asthma eosinophilia, think of the EGPA, but EGPA needs other differential diagnosis. Means at least the 4 out of 6 criteria, as I say, the bronchial asthma, eosinophilia, mononeuritis multiplex, and then get back the Pianka positivity and the sinusitis, the upper respiratory tract sinusitis and lower respiratory infiltrates. So these needs the mononeuritis multiplex and Pianka at least positivity, but APPA here, the asthma eosinophilia, but the IgE will be very, very high. And the diagnostic test, of course, the Rust antibody or maybe the Aspergillus specific precipitants antibody is the likely diagnosis. Just to differentiate from the APPA, the diagnosis is given here, the EGPA miter. The next is the question number. Once again, was the likely 60-year-old man attends to the clinic, shortness of breath, preceding 2 months, he has had the problems with the nasal irritation, discharge, and sinus pain. So nasal irritation, discharge, and sinus pain. She is known to have the asthma, once again, which has recently been poorly controlled despite inhaled steroids, and her full blood count shown in eosinophilia, so more than 10%, and peripheral pulmonary shadows. So once again, the diagnosis peripheral pulmonary shadowing, once again, the bronchial asthma with eosinophilia, and along with the, yes, this significant eosinophilia, and also the upper respiratory tract involvement. There is the sinusitis, nasal discharge, and also the pulmonary infiltration. So the 4 important criteria is more likely going for the eosinophilic. Always EGPA is the likely diagnosis. So what is written, you see the sinus disease, extravascular, the 6 important criteria. So yes, the vasculitic phase, the mononeuritis multiplex. The question number here, yes, once again, which of the following is the most likely diagnosis? There may be the EGPA here, EGPA, yes. The another diagnosis is the PAN, another is the GPA, but polymyalgia actually less likely because this is not our discussion. So, right. So 50-year-old man referred to the 2 weeks history of the fever, arthralgia, weight loss. During his hospital stay, he develops the epigastric pain and notice difficulty in dorsiflexing his pain. So circle the pain, dorsiflexing is greater. His blood pressure is high. Laboratory studies the hemoglobin low, MCV 98, ESR is very, very high, CRP is high, and polymorphonuclear leukocytosis. Chest X is clear. So if you get back from here, so here is definitely as I said, the fever, rash, arthralgia. Yes, once again, fever, rash, arthralgia. And also the frame, as I said, the malice, the vasculitis, no doubt. But he has got the epigastric pain. This is important. Yes, my dear. So epigastric pain. We discussed a disease like the GPS, GPA, EGPA, and also the MPA. There is nothing that we studied, the epigastric pain. So if you think about the GPA, definitely the upper respiratory tract followed by lower respiratory tract. But there is nothing the upper respiratory tract involvement in this scenario. So this is not the case matter. Next, if you get the Shastra's EGPA, so the patient should have the bronchial asthma with eosinophilia. So this is not the case. Done. Now the polymyalgia rheumatica, there will be the proximal myalgia, that should be there, proximal muscle myalgia with the morning stiffness. So this is not the case. SLE, the young female, usually the case with the vasculitis as the presenting with the facial rash, arthritis, synovitis, mouth ulcer, discoid lupus erythematosus. So the diagnostic criteria. So if you exclude them, so you have in your hands the polyarthritis notice, it's a separate lecture, my dear. At least the PAN, the box that you will learn by the PAN lost means the weight loss is an important point here. Yes, now you can get the PAN means the pain, and pain, my dear. Pain, and pain. Yes, my dear. So there are so many pains. Yeah, of course, the abdominal pain if you get back, and once again the neuropathic pain, and also the blood pressure is also another important points, and the inflammatory markers. So it's a separate lectures for the PAN. Just a exclusion. I don't like to go for the PAN lectures now, but just having the abdominal pain, highly susceptible mesenteric ischemia, and mononeuritis multiplex of vasculitis, and refracted in patients and loss of dorsiflex left greater. So other diagnosis, exclusion might. Then what is the most likely diagnosis? Yes, if you get back on the 44, rhinitis, asthma, tender subcutaneous, the antibodies to the Pianka positivity, eosinophil. So asthma, eosinophilia, once again, the EGPA is the likely diagnosis. Next is once again, which one of the following vascular is more often to the renal? As we said, the MPA is the likely answer. And next, once again, question number 9. Yes, which of the following is the most likely diagnosis? Once again, the urine hematuria, proteinuria, and the ESR is raised, and also the creatinine is high. And if you get back 45, history of the chronic sinusitis, upper respiratory tract, and the shortness of breath, lower respiratory tract, once again, the GP is the likely diagnosis. Here, and now he said, yes, he has past medical history. Yes, once again, past medical asthma since childhood, which is well controlled. So this is a red hearing, my dear. So don't go for that. On examination, heart BP is high, and also there's scattered crackles and collapse of the nasal bridge. So collapse of the nasal bridge, upper respiratory tract, lower respiratory tract, hypertension. Definitely the GP is the likely diagnosis rather than EGPA, my dear. Be careful about it. the childhood asthma is well controlled. If it's not controlled, definitely think about that. And eosinophilia should be there. So yes, my dear, the next very important question. So the next question you see, which of the following the HLA types is most likely associated with our conditions, my dear? So if you get back above, chest X-ray patchy shadowing, both lungs, anti-GBM antibody positive. So definitely anti-GBM antibody disease, done. No other disease, my dear, just grip it. Now you can get back the hematuria, proteinuria, definitely the RPGN, the creatinine is high, potassium is high, and hemoglobin is low. So once again, she has a bibasal crackers and auscultation in the chest, abdomen soft and non-tender, hypertension, 45 represents emergency, large hemoptysis. And she has suffered from the increasing nausea, lethargy, 2 weeks, and blood pressure is high. So presented with the hemoptysis means the pulmonary hemorrhage, with the renal failure means the RPGN, with the anti-GBM antibody positive renal pulmonary syndrome, with the pulmonary shadowing, definitely the diagnosis, the Goodpasture syndrome. As you say, the Goodpasture syndrome is strongly associated with the HLA. Dr. Bangladesh number 1. Yes. Dr. Bangladesh number 1. Star 1501. And also the one other important points that you need to learn, my dear, this one, that is nothing but that you need to know the restricted T-cell epitope. T-cell epitope. Restricted T-cell epitope. Yes, my dear, restricted T-cell epitope is strongly associated. We know that the GPS is associated with the HLA-DR2, but now specifically this you need to know that is GPA, GPS means the Goodpasture syndrome or Goodpasture is strongly associated with the HLA doctor. Yes, my dear. You see the Dr. Bangladesh 1, so you need to remember Dr. Bangladesh 1, 1501, and also the restricted T-cell epitope is strongly associated, is recognized, playing an important role in injury of the anti-GBM antibody syndrome. Another question, yes, my dear, is the which of the following is the most likely diagnosis? Urine hematuria. Once again, respiratory function cases increases, nothing but the pulmonary hemorrhage. So, renal pulmonary syndrome, done. The diagnosis, you should think of bilateral and creatinine high, potassium is high, and WBC is high, and hemoglobin is low, inflammatory markers. 42-year presents with emergency rapidly worsening shortness of breath over the past 24 hours and cough, blood stained sputum. She smokes 5 cigarettes per day, only medications, no progesterone, only pill. On further question, she tells you that there have been problems with increasing fatigue over the past few weeks, and she consulted her GP on 2 previous occasions because of the sinusitis. So yes, the upper respiratory tract followed by the lower respiratory tract. On GP, BP is a yes, once again, the bilateral wheeze on auscultation and the crackles and the respiratory rate and also saturation. So renal pulmonary syndrome, upper respiratory tract followed by lower respiratory tract, definitely GP is the likely diagnosis. So yes, my dear, you see that if you know the knowledge, my dear, splitted and fine-tuned knowledge, my dear, you'll be able to make the answers correctly with confidence. So let's see once again the few questions that are left behind. So which one of the following is the most characteristic radiology find in chest X-ray in this case? 40-year-old woman presents with a hematuria, recurrent hemoptysis. Hematuria, hemoptysis, renal pulmonary syndrome, the clean-cut GPS, my dear. So past medical history of the hypertension, blood pressure, low hemoglobin, renal biopsy, presence of the anti-GBM, so anti-GBM antibody syndrome. So in the chest X-ray, what you're expecting, definitely the diffuse bilateral infiltration in the lower zones in case of GPS having the pulmonary hemorrhage causing the hemoptysis. The next scenario, you see that which of the following was a positive antibody in this case. Chest X-ray shows the bilateral pulmonary urinalysis, so renal pulmonary syndrome, rheumatoid factor positive, and then ESR high, creatinine, once again they are high, WBC once again 10, and this is hemoglobin. 32-year history of the asthma managed by the GP, now presents to the weight loss, abdominal diarrhea, skin changes, past history, he has become increasingly lethargic, feelings of nausea, and other past medical history includes the episodes of food drop, which occurred 3 months back. So having the asthma diagnosed, managed by asthma, and seeing the bilateral urinalysis, so definitely you should think about the Pianka positivity, because this is nothing but the eosinophilic. EGPA is the likely diagnosis. So having the you need to know the eosinophils, my dear. So asthma with eosinophils, once again, the likely diagnosis with the mononeuritis multiplex, the 3 important criteria. Asthma, eosinophilia, vasculitis in the form of mononeuritis multiplex. So definitely anti-MPO means the anti-PianCA means the PianCA antibody is positive. Some few questions are left behind. So once again, what is the most likely diagnosed answer is the methotrexate pneumonitis, but having some of the differential diagnosis, why this is given. You see the partial oxygen is a 7.8, means the less than 8 kilopascal, and once again partial carbon dioxide is reduced, gas transfer factor is reduced, forced vital capacity is 81%, forced vital volume in the first second 84%. Yes, my anti-GBM antibody negative. So creatinine, that's why actually it's come here, the creatinine and is high. And also the WBC and hemoglobin slightly normal. Okay, fine. 70-year-old woman required rheumatoid arthritis comes to the clinic. Recently, she has been suffering from the increased shortness of breath. Yes, my dear. So rheumatoid arthritis patient, shortness of breath. Yes, takes the diclofenac for the arthritis, smoking history, her blood pressure, mildly clubbing. So clubbing, my dear, this is important. So clubbing in the throat, the crackles, inspirated crackles. You say the inspirated crackles. So shortness of breath with the crackles, that definitely diagnoses the rheumatoid lungs, means the rheumatoid arthritis causing the pulmonary fibrosis, the first diagnosis. And second diagnosis, you should think about the MTX pneumonitis. So the differential diagnosis said the MTX pneumonitis is important. Definitely this is not an asthma, this is not a COPD, this is not a pulmonary embolus, this is not a pulmonary hemorrhage. Very important, my dear. Question number 294 is, what is that? What diagnosis best fits this clinical picture? So you see, if you get back 23-year smoker, 30 cigarettes per day, presents with a rapidly increasing shortness of breath, cough hemoptysis over the past month following chest infection, chest X-ray demonstrates diffuse alveolar infiltrates, and blood testing raise the urea and creatinine. So yes, of course, the renal pulmonary syndrome with the anti-GBM antibody positive definitely diagnoses pulmonary hemorrhage because of the pulmonary transfer factor is elevated. So the Goodpasture syndrome is a likely diagnosis. Next one, once again, you see that the 22-year, what is the best pairs? Once again, the baseline, the linear pattern, the depositions of the glomerular base and IG, definitely the single diagnosis, the GPS. Definitely you can confirm the diagnosis by other differential criteria. So which one of the following the most likely diagnosis in this case? If you get back, so once again, the 52-year-old man visiting GP while completing recurrent nosebleeds. So definitely the upper respiratory tract, and she has consulted cosmetic surgery, advising the shape of the nose, yes, the saddle nose, dipping and peasant examination anesthesia private surgeon. Perioperative blood testing reveals the anemia, hemoglobin, irreliance hematuria, so the renal involvement, proteinuria, surgery, cold and serum creatinine. Yes, my dear. So upper respiratory tract, once again, is the GPA is the likely diagnosis. Next question, what is the most probable diagnosis? Once again, 40-year-old man, 6 weeks history, tiredness, cough, shortness of breath, mentions that he had episodes of hematuria. So the cough, hematuria, renal pulmonary blood test positive for PianCA and negative for anti-GBM eosinophil count. So this is important, my dear. So eosinophil count is 0.3. Yes, my dear, 0. Yes, normal. So what is the likely diagnosis? Very important. So if the eosinophil count is 0.3 is normal, so you can count the EGPA. Once again, positive for PianCA. So PianCA positive, very simple. Diagnosis, two diagnoses, maybe EGPA or the MPA. So at the EGPA you cut, so the rest is the MPA is the likely diagnosis. That is a microscopic PolyAngiitis, my dear. So yes, my dear doctor, so what we've done, my dear? We've gone through the lectures for the differential diagnosis of renal pulmonary syndrome. On the headings of the RPGN, on the differential diagnosis, the long list of differential diagnosis, to clinch each and every disease is very important for the hot topic for the exam, my dear. And definitely the GPA, GPA, MPA, EGPA, all are very important 5-star topic for exams writer. And definitely this knowledge we applied into the different scenarios, having some of the spirited and fine and tuned knowledges under the headings of the RPGN. That helped a lot, my dear. Definitely you will do the best, and I hope that you enjoyed. Thank you very much.